Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an obesity expert on how the subject is being redefined, and we'll also review pharmacology and surgery. Well, for Australian audiences, listening does give you eligibility for your CPD, so you should log in and add this as an activity. You may also consider journaling, reflecting and adding to the review and performance section in your CPD. I think, as everybody now knows, obesity has reached crisis levels in Australia, with 67% of Australians now classified as being overweight or obese based on 2022 data. BMI measurements have been used in epidemiological studies to define overweight individuals with a measurement of 25 kilograms per metre squared and obese individuals with a BMI measurement more than 30 kilograms per metre squared. It is now recognised, however, that BMI-based measures of obesity may both underestimate or overestimate adiposity and provide inadequate information about health at the individual level and subsequently undermine medically sound approaches to healthcare and policy. A recent commission of 58 experts in this field reported a consensus in the Lancet defining obesity as a condition characterised by excess adiposity with or without abnormal distribution or function of adipose tissue and with causes that are multifactorial and still incompletely understood. They subsequently teased out the diagnosis of obesity to include preclinical and clinical definitions, where preclinical obesity is defined by excess fat accumulation as measured by direct means with DEXA or indirect anthropometric measurements such as waist to height, waist circumference, or waist to hip ratio measurement. This group of patients have no clinical disease or end organ damage or symptoms as yet, but an increased risk of developing clinical obesity and conditions such as type 2 diabetes, cardiovascular disease, and some neoplasms. The treatment focus in this group includes counselling and the introduction of measures to prevent progression to clinical obesity. The Commission recommended that BMI should only be used as a surrogate measure of health risk at a population level for epidemiological studies or for screening purposes rather than as an individual measure of health. However, for people with very high BMIs, so patients with BMIs greater than 40 kilograms per metre squared, excess adiposity can be pragmatically assumed. Well, the next subgroup is clinical obesity, which the Commission defined as a chronic systemic illness characterised by alterations in the function of tissues, organs, the entire individual, or a combination thereof due to excess adiposity. Clinical obesity can lead to severe end organ damage, causing life-altering and potentially life-threatening complications. And the main focus of management for this cohort is to improve end organ dysfunction as a priority rather than to focus on weight loss alone. Treatment options include lifestyle modification through diet and counselling, and rely on established pharmacology such as with GLP-1 receptor agonists, which are likely to be used as a long-term treatment strategy. Well, for a select number of patients, however, these medications can induce nausea, vomiting, diarrhea, constipation and reflux, and in more serious cases, cause gastroparesis, with pancreatitis also described. And non-responsiveness and high cost of medications may be a limiting factor amongst some patients, and consequently, surgery remains the cornerstone for safely and effectively managing obesity and includes both gastric sleeve and bypass operations. Well, to discuss this new definition of obesity and approach to thinking about obesity, as well as to review surgical options, I was curious to open a discussion with Dr. Melissa Beitner. Melissa is a fellow of the Royal Australian College of Surgeons. She is American Board of Surgery certified, a fellow of the American Society of Metabolic and Bariatric Surgery, and is a diplomat of the American Board of Obesity Medicine. Melissa is incredibly well credentialed, having undertaken bariatric surgery fellowships at Mount Sinai Hospital in New York, Royal Brisbane and Women's Hospital, and St George Hospital, Sydney. She has special areas of interest in bariatric surgery and obesity medicine, and is also highly skilled in hiatus hernia and anti-reflux surgery, cholecystectomy, and general surgical removal of lumps and bumps. So please welcome Melissa to the podcast. Dr. Melissa Beitner, welcome to Everyday Medicine. Very nice to meet you.
Thanks so much for having me.
Well, thank you for being here. when you've got a very busy schedule and being a bariatric surgeon, you've got lots of challenges. So it's such a big subject, such a topical subject, and it's very, very nice and a privilege for me to have you and to be introduced to you in this way. You know, obesity in Australia has sort of reached crisis levels, I guess, in the Western world it has generally, and it's often quoted that about 67% of Australians are either overweight or obese. So I do want to talk about that and about your journey through bariatrics. And I wonder if I could start with that, your journey through medicine. Take us, how did you get to this lofty position? Take me through it, because you've got a very interesting story.
So after high school, I went to medical school and I went to the University of Melbourne thinking that I was going to be a physician. But then when I did my rotation as an intern at the Alfred on the upper GI and bariatric surgery unit, that was really what made me fall in love with bariatrics. That and having seen, lots of people in my personal life suffer with obesity and just seeing how transformative it could be. And so that completely changed my mind. I abandoned becoming a physician and I decided I was going to do bariatric surgery. I was going to be a physician and I was going to train at the top place in the world with the top surgeons. And so I set along a path of moving to the States. I did a Master of Surgery focusing on bariatric surgery, which got a very good publication out of that. And then I did my general surgery training at New York University. And then I did fellowships at Mount Sinai, which is in New York. And then I came back to Australia and I worked with some of the most prominent bariatric surgeons here in Brisbane and Sydney. And then I eventually came back to Melbourne and set up my own practice.
Yeah, that's an incredible story and takes a lot of guts, that's right, for you to do that. But, we sort of need you on, this is my story type. I'm always impressed to hear like other specialist stories, because it often takes a huge amount of courage and drive to do what you've done, to leave Australia to go and work overseas, by yourself, to make your own path and then to come back. It's very uplifting to hear that story. And of course, we're wishing you all the very best here in Australia, building your practice. And I know you worked with George Fielding, who I met when I was working in Brisbane. And, so he's one of the best, certainly was at the time. And your skills will be very well honed. Just tell us a little bit about the approach to obesity now. We've got slightly different definitions that are coming in. Can you upskill us in terms of the definitions here?
Okay. So, well, technically the WHO definition of obesity is an abnormal or excessive fat accumulation that presents a risk to health, and it's considered a chronic, relapsing and progressive disease. Now, I guess the hot topic that came out in January was the Lancet Commission, which sought to redefine clinical obesity. And one of the main questions that they asked is obesity actually a disease versus is it just a risk factor? And what they came up with was basically an algorithm that defined preclinical and clinical obesity. So in patients who have obesity, they have an excess of body fat, and they move the focus away from just what your weight is and to how it's affecting health. So if you have signs and symptoms of end organ dysfunction as a result of your obesity, or there's an impairment in your activities of daily living, then you are considered to have obesity, clinical obesity.
So are we getting a little bit away from the BMI definition?
Yeah, so that's another one of the main things that this commission sought to clarify, that the definition of obesity should not be based solely on BMI, but on other anthropometric measures such as your waist circumference, waist to hip circumference, and ideally also on your percentage body fat. Yeah. Now, in reality, I think that this is adding a lot of complexity to the diagnosis of obesity, and certainly it favours patients who traditionally have weighed less, but certainly suffered from the consequences of obesity. I'm sure you know about, patients who BMIs are in the low 30s but have, significant metabolic disease, favouring the treatment of those patients over patients who are metabolically healthy but might be a higher weight. So there's lots of there are lots of criticisms of this new paradigm. Certainly I'm a critic of it myself, and I don't know if it's going to be widely accepted, but this is certainly something that everyone's talking about at the moment.
I think probably clinically, when primary physicians, general practitioners and so forth, see patients who are very overweight and are now developing type 2 diabetes, are part of the metabolic syndrome. And of course, we often get these patients as well because they're referred for fibro scans where they're concerned they're getting cirrhosis and so forth and so forth. It's often the patient, I think, that will also drive the question of what should I do about my obesity. And I doubt that. I might be wrong, but I doubt that in primary practice people are getting out skin calipers and doing some of those other measurements. But I guess it sets in our head the idea, well, we need to look at obesity, as you say, as a disease. What are the end organ effects of obesity? It's got to be taken seriously. And well, here's a group of definitions around how we're going to sort of manage it going forward.
Yeah, absolutely. I mean, personally, I prefer the Edmonton Obesity Scale, which I am not sure if you're familiar with.
Tell us about that.
That divides obesity into 4 stages, but it has three umbrellas. It's the medical side, the mental side, and the functional side. So one of the things that the Lancet Commission, this definition completely ignores is the mental side of obesity. So, you can have patients who currently don't suffer from any metabolic consequences or any other types of medical consequences of obesity, and they aren't impacted in their activities of daily living, but the mental toll is enormous. Like, they're not functioning in society the way they could potentially be if they were at a lower weight.
Yes.
And honestly, when patients come into my office and they burst into tears, it's not because their diabetes is so bad. It's because of the functional and the mental side and the toll that that's taking on their life.
Yeah, and often the patients feel helpless, don't they? That they've tried a variety of things, dietary, lifestyle type changes, and they don't seem to be able to succeed in that way. It's just not possible for them, and they feel incredibly frustrated by it, and then they're stigmatised by it to some degree. Yeah,
100%.
And whether we call it fat shaming or whatever, I guess people feel a certain degree of shame, don't they, in some situations? As much as that's not necessarily a nice term. Edmonton, that's out of Canada. So I wonder if Mr. Trump's put a tariff on that definition. So I'm very interested to see, what is your approach? Someone comes to see you. I refer you someone, Lisa, and say, look, I'm worried about this patient because their BMI is up and they do have some end organ changes that we're worried they're getting metabolic damage and so forth. Could you, and the patient's, of course, consenting to seeing you, what's your approach to a patient, and maybe you could go through patients who have got different levels of obesity. What's your approach? Take us through how you manage them. What should we be doing?
So, of course, my approach is always going to be individualized.
Yes.
And it's very much a grey zone for patients who have a BMI, that's between, 30 and 40. This is really clearly a grey area. I think my personal approach is that patients who have a BMI over 40, they're not going to achieve the weight loss that they likely desire with anti-obesity medication. But I certainly present to them all of the options. Obesity is a very complicated disease and it affects everyone differently. And as we have just, discussed, even the diagnosis of obesity is very highly nuanced. So you need to take into consideration what patients' goals are, what their age is, what their medical comorbidities are, their weight history, what they've tried in the past and what they're open to. So, there's many, many things that we need to take into consideration. And referring a patient to someone who specialises in the treatment of obesity and offers a range of treatment options is ideal, because then they can help select the appropriate treatment for the appropriate patient. It's very challenging when you refer patients to someone who only does one type of thing, because they're only going to offer them one type of thing.
Yes.
And, it's surprising. Lots of patients don't want medications. Other patients definitely don't want surgery. So you have to work with the patient.
If they haven't tried pharmacotherapy or major lifestyle changes, and that would be pretty unlikely, I think, these days. But just suppose they haven't, what would be your kind of choice there in terms of offering that very first level of treatment, which is the medical side?
So lifestyle change is really the cornerstone of successful weight loss. Whether you're doing that alone, you're using medications, you're using a non-surgical procedure like an endoscopic procedure or you're using surgery. Like, you have to change your nutrition, your physical activity, your behavior, and your habits. Like, all of these factors must be addressed in order to be successful for weight loss. So that's going to be a key component in any therapy we choose, and first line. But, we're also realistic. If you have a BMI of 60, and I know I'm still talking about BMIs, but,
Yes.
lifestyle intervention alone is not going to get you down to an appropriate weight. And yes, losing 5, 10 or 15% of your total body weight is going to have an improvement on your health, but it's probably not going to be enough for patients who are as heavy as that.
No. What would be your go-to lifestyle type change as a pharmacotherapy? If that was,
Which pharmacotherapy?
Yes. Someone comes in, they actually haven't been placed on anything. What do you choose? What's your recommendation?
So I think that most of the data suggests that Mounjaro has superior weight loss outcomes to Wegovy. So in the SURMOUNT-5 trial, which is where they, under trial conditions, they compared Wegovy to Mounjaro, patients on Mounjaro lost 20% of their total body weight compared to 13.5% with Wegovy. But there have been other studies where they've compared these two medications in real life, so not trial conditions, and I'll explain what that means, where people on Mounjaro after a year are losing more like 15% of their total body weight, and people on Wegovy are losing 8%. And so if you look at the fine print for what they're actually doing in these trial conditions, patients have a 500 calorie per day calorie deficit, and they're doing 150 minutes of physical activity per week. So if people in the real world aren't doing those things, well, they're not going to recreate trial results. Yeah. So when I start patients on medication, I explain all of this to them, and they work with a dietitian. Often they also work with a psychologist, and we aim to recreate those trial conditions.
How successful are you in managing to get a calorie deficit and holding the patient to account to that? Do you have a special technique for that? Because it does seem like, well, if we can do that, it ought to work, but it doesn't often seem to. Do you have how do you hold them to account? Have you got a,
well, I always stress that
phone calls?
We support our patients as best we can, but we also want to empower them to know that actually they're in control of things. So these medications are extremely powerful, and so when you're on them, you're going to see the benefits. The problem is when you're off them.
Yes.
Yeah.
Okay. So when someone perhaps then advances to a bariatric surgery, do you keep those pharmacological therapies going? Are they required long term? Is there any evidence that we should keep them going? Or is that based more on the clinical outcome of the patient post-surgery?
It's so new that there is not strong clinical evidence for it. I know that there are some clinicians who are using anti-obesity medications preoperatively and continuing them post-operatively. However, I'm reluctant to do so. Firstly, there's data now that people who use anti-obesity medications before surgery do not lose more weight in total than people who didn't.
Right, okay.
And their surgeries aren't safer. And then there's the issue of anaesthetic risk. So these medications have a long half-life, and we know that they delay gastric emptying. So there's a risk of aspiration during surgery. Now, although that might be, well, of course it's never okay, but it's more of an issue when you're actually operating on the stomach. You can't really afford to have any contents in there. Yes. So you do need to stop it perioperatively. And then the current guidelines recommend that if you are going to initiate them, you should wait until patients have plateaued in their weight or they're starting to regain weight. So that time frame might be variable.
Right, okay. Do you understand why sometimes these drugs are given and patients will lose weight and then they do plateau out? Still we'll use the term BMI, still at the BMI that's perhaps not considered to be at all healthy, but they tend to plateau out at a certain point. Do you understand that? I've often wondered why, well, if we're losing a certain amount of weight per month or per whatever 6-month period, why do we plateau out? Or is that not, maybe this is my experience and it's not your experience, but
well, there is an expected weight loss with these medications. It's not indefinite, right? So it's not like you're going to lose 100% of your excess weight with these medications. There's a specified amount, which is an average. And if you break that down, you see that it's only about 50% of patients at the highest dose who are losing the larger amounts. And I mean, I'm not sure of the biology behind it, but it seems like there is a tolerance that people develop to these medications. Otherwise, why else would you need to continually escalate the dose?
I find that sort of fascinating. I just don't understand why it should plateau out specifically. Although I will tell you my experience, Melissa, which has got probably no relevance at all, but I eat one meal a day and I noticed my weight has stabilised where I am. I feel cold. I feel colder. If I swim in the ocean, which I love doing, I shiver quite a lot, but I'm not dropping any further. And whether I eat less or eat more, I just pretty much hold this. Well, it's just interesting for me because it's just plateaued out. It dropped and then it plateaued. And I am interested in the biology of why it doesn't just continue to decline until there's that, that healthy BMI or whatever that is reached. I think that's fascinating.
It is. It's a very complicated mechanism. We all have set points. And, once we do reach a plateau, we do need to change our behaviours to get further results.
We have to do something else to shock the system a bit.
Yeah.
Okay, so we've gone through some lifestyle changes and you've got the psychologist helping dietitian. You've done some pharmacotherapy in those that you felt would benefit from it. But then the decision is made, well, we're sort of plateauing out. We've got these end organ concerns and we might do some bariatric surgery next. So what is your approach to all the various bariatric that bariatric toolkit? You've got lots of things up your sleeve, gastric balloon and so forth. We'll hear about what you recommend. But just take me through that. What's your thinking there? Where do you go?
So gastric balloons, which we kind of consider non-surgical procedures, they're temporary.
Yes.
You can lose between 10 and 15% of your total body weight with that. With the temporary ones, yes, some of that weight loss is sustained, but there isn't really great long-term data suggesting that once the balloon is out, your weight loss will be sustained. Surgical procedures, on the other hand, we do have a variety, and there are new techniques being developed all the time, which is super exciting. And the landscape is constantly evolving for a period of time. There were VBGs, and then there were gastric bands, and then there were sleeves, and now there seems to be more of an uptick in mini bypasses, and who knows, in the future there might be magnetic anastomoses. That's certainly getting a lot of buzz at the moment. Might replace the SADI operation, which stands for single anastomosis duodenal-ileostomy.
Right. Okay.
So things are changing all the time.
Take us through your approach. What's your go-to? How do you work out what you're going to do?
Again, it's always a discussion with the patient, and every operation has its pros and cons. In general, patients who are higher weight, who have more weight to lose, we favour bypasses. And there are different types of bypasses. So there's the Roux-en-Y and there's the mini gastric bypass. And in terms of weight loss, long-term, mini gastric bypass has superior weight loss. But in terms of sleeve versus bypass, Roux-en-Y gastric bypass, Roux-en-Y has superior outcomes. There's actually a randomised controlled trial done called the SMBOSS trial, which was a head-to-head trial between patients who had a sleeve or a bypass, which is I would say it's easy to do because patients have no idea what operation they've had done. Their preoperative care and postoperative care is the same and they feel the same, right?
Yes.
So the 5-year data from the SMBOSS study suggested that sleeve and Roux-en-Y gastric bypass were equivalent in terms of weight loss. Not statistically significant. Okay. But now that they have 10-year data, which was published just a few weeks ago, actually the Roux-en-Y gastric bypass has superior weight loss, but it's not as good as a mini gastric bypass. So I think younger patients, this is my approach, younger patients who have less weight to lose, patients who don't have terribly much reflux, patients who we know need to do a 2-stage operation, or even patients who are planning to get pregnant soon, we favour a sleeve. I favour a sleeve. It's still the most commonly performed operation in Australia.
Yes.
Like last year, 2023, the Bariatric Surgery Registry reported that 80% of bariatric procedures were a sleeve. Yeah. It's just the most popular.
And that seems to be very well tolerated. As you mentioned, the side effect of the sleeve could be enhanced reflux. We don't see in gastroenterology, maybe those patients aren't coming to us so much, they're going back to the bariatric team, but see a huge number of those cases, Melissa. I know it's talked about a lot, but don't see a huge number of them. But, I'm not sure whether you're seeing more of those sorts of complications.
They probably present to the bariatric surgeon.
And we're not necessarily getting involved with them so much. So that's the only concern. So if someone does have a history of reflux and they've got a hiatal hernia, it's just complicating that clinical problem, you might not therefore end up recommending a sleeve. Or if the PPI dependent, you might have that conversation and perhaps say, well, maybe we're not going to do a sleeve for you because of this concern. Yeah.
Yeah. I mean, it's further complicated by the fact that you have an anatomical disruption when you have a hiatal hernia. And that fixing the hiatal hernia will often make a big improvement in their reflux symptoms. So there is data to suggest that if you do a sleeve with a hiatal hernia repair, their reflux is, they have less reflux or less likely to develop de novo reflux.
Right, completely the opposite of what I just said. Okay, that's fine. So what would you say is a contraindication then to doing a gastric sleeve? What would contraindicate? Not leaving the BMI perhaps out of the equation. You're going to choose, you're thinking about doing a sleeve because you think it's appropriate. What would make you think, I shouldn't do that?
The recommendations are that if you have Barrett's,
yes,
you probably shouldn't be doing a sleeve.
Okay. All right. So it's more along that line. Okay. You've mentioned the Roux-en-Y, longer term better than the sleeve, but the mini bypass is better than the Roux-en-Y. Just explain the mini bypass again to us. Just take us through that omega loop.
So all bypass operations involve making the stomach smaller and rerouting part of the small intestine. And there's just different configurations. So with the Roux-en-Y, you have two anastomoses. You have a gastroenterostomy and you have an enteroenterostomy. Two anastomoses.
Yes.
And the configuration is something that we do for many types of operations, right? Roux-en-Y hepatocogenostomy.
Yes.
Many types of operations. A mini gastric bypass is a single anastomosis. So instead of dividing small bowel, we just bring a loop up and connect it to a small stomach pouch.
Yes. Okay.
Yeah, and part of the reason that the SMBOSS study did not compare sleeve with Roux-en-Y gastric bypass is that
with a mini bypass,
mini bypass is because mini bypass was not an approved operation in the US until very recently. So people have not been doing it over there.
Okay. So now in Australia, is there a shift now for bariatric surgeons to generally do the mini bypass, the single anastomosis technique?
I think that it's on the rise because we see that it has fewer complications than a Roux-en-Y. Having one anastomosis, there's just one site where things can go wrong.
Yes.
And it has superior weight loss.
Yes. What side effects do you see with that operation that could be a concern for people in primary practice?
So nutritional deficiencies, certainly. And you also have a risk of developing bile reflux.
Okay.
Because with the Roux, your alimentary limb, which is your food limb, is disconnected from the meat limb, right? It's very far away.
Right.
Whereas here, the BP limb and the alimentary limb are continuous. So it's easy for the bile to reflux up.
So that's the main concern. Do you see patients with diarrhea or other concerns arising from that? Is that a clinical problem that we could expect?
It tends to not be too bad because we're usually only bypassing between 100 and 150 centimetres of small bowel. It's not like the old procedures like BPD or even the SADI operations. These are duodeno-ileostomies where we have short common channels. These people have common channels 5 metres plus usually,
Do you know how it was worked out that that's the amount of bowel that should be bypassed? Do you know how that decision was determined?
In a mini?
Yes. And you think, it's a larger person, I'll bypass even more. That's not the approach that's taken, though, is it? We'll try and bypass even more. But,
there is the concept of tailoring the BP limb, but it's not by many metres. It might be by 25 centimetres, 50 centimetres.
Right, okay.
Yeah.
Okay.
Currently, these very short common channels with BPDs, 200 centimetres, even less than 300 centimetres, they get really bad problems with malabsorption.
Yes, okay. Now, you have a little hint at the future there. So take us through that. So we're talking about magnetic anastomosis. You're talking about magnets being put on the bowel on both sides, and then the magnets, of course, are drawn together, and necrotic tissue.
Yeah. It's so exciting. It's really, and it's so innovative. And that's why I love bariatric surgery. Like, even in my short career, things just keep changing and keep evolving, and the technology just gets better and better. So with the magnetic anastomosis, basically you're aiming to form a fistula between two loops of bowel. So the procedure is called the MAGD. It's magnetic anastomosis duodeno-ileostomy. So it's like the SADI.
Right, the MAGD. Okay.
You do a sleeve, or you don't even have to do a sleeve. They're also not doing it for sleep. They're doing this for diabetes as well. You put one magnet in the duodenum, so you just endoscopically place that, or they swallow it, and the other is placed in the jejunum. So usually you swallow that like an hour before surgery, and so it makes its way into the jejunum, and you use instruments that have magnets on them to put it in the right position in the jejunum. Like, let's say you want to have a 300 centimetre common channel. So you'd put your second magnet there, and the other one you'd put endoscopically or have them swallow on the table. And then you just line them up, and that's it. That's the duodenal. You still have access to the biliary tree. So
which is a big advantage. And that's a disadvantage with the Roux-en-Y and the omega bypass, because it's difficult to get back into the biliary tree if nucleophysis arises, ERCP becomes very hard. That is fascinating. Is that's being done at the moment, Mandy, or is it an approved procedure in the United States yet to come here?
Not approved. It's under IRB approval. So even in Australia, it's being done under trial conditions. But it was pioneered by Michel Garnier, who's a bariatric surgeon at McGill, or he's in Montreal.
Right, I see. And so you don't actually have to fashion surgically a joint. The joint arises because you've got bits of bowel that are pushed hard against each other, held there by the magnets, and eventually the tissue breaks down and a fissure.
I think you pass it in your stool in a couple of weeks.
Right, okay.
They're also using this magnetic technology in colorectal surgery for malignant obstruction.
Yes, yeah. I've heard the colorectal surgeons talking about this. It's fascinating. Is there any other techniques that are being honed or considered, or other things that on the horizon that are exciting?
I think just they are experimenting with placing these magnets in different positions, duodenum versus stomach. So you have what's called bipartitioning. So you have, one anastomosis, but you also still have access to the biliary tree.
Yes, it's a lot of interesting interventions.
I guess the other thing that's talked about a lot at the moment is combination therapy. So it seems to be that the combination of bariatric surgery with anti-obesity medication is synergistic, and so patients who do both have better outcomes.
Well, that's fascinating. Take us through where do you see I guess that's part of where the future is going to go with this. What else do you sort of feel is going to sort of develop in this whole space of managing obesity? Do you have any other thoughts? I know you're on the surgical side and we're talking about these very exciting things.
I am very heavily interested in obesity medications, and I actually got an additional board certification as an obesity medicine specialist because I wanted to take a holistic approach to the treatment of obesity, and I wanted to fully understand them so I stay up to date with these medications. So, there are so many medications in development, and there's like this arms race to develop the medication that leads to the highest total weight loss. Right? And there's big money involved in this. I think one of the things that they're experimenting with at the moment is different medications, often used in combination with the GLP-1 agonists that inhibit muscle breakdown, because this is one of the downsides of these GLP-1 agonists, is just loss of lean muscle mass.
Yes,
which
I see.
To avoid.
Yes, I see. Have you used topiramate? Coming back to pharmacotherapy, topiramate is something that I have prescribed previously, and of course there are some rules around where you should be using topiramate because it's not approved by the PBS for weight loss, like some other drugs as well. But have you had experience with that? I wonder if that's the sort of combination that we're going to be using, that sort of thing with the GLP-1 agonist.
So far, no, I haven't used it because the weight loss that you get with topiramate is really, really minimal. So,
it's not that big.
Yeah, and there are some combination therapies that are around, but again, they don't come close to these GLP-1 agonists.
Yes, yeah. I can't help thinking, Lisa, there needs to be a change also in government in terms of I'm not saying we should have a tax on sugar. There's so many taxes around, but I've interviewed people and talked to them about the concerns about sugar intake and refined carbohydrate intake, and I just can't. I would like to see somehow a public health approach, just perhaps educating us all on what a healthy diet should look like and what an appropriate amount of calories should look like, exercise should look like, and how consuming refined carbohydrates and sugars perhaps is not actually the best, as addictive as it is. I'd love to see a little bit more interest from the government in terms of public health initiatives just to guide our community who don't quite seem to understand, what is a healthy diet. Now, I understand obesity is much more complex than just that alone, but I do wish there was that push. We need you on a committee. We need you on a government committee, Melissa. Pushing hard.
I mean, it is such a complex issue. It's governmental, it's societal, it's genetic, it's environmental. It's there's so many levels of so many factors that contribute to the obesity problem.
Yes. I was listening to Gabriel Mate talking. He was on a conversation podcast I was listening to, and he was talking more about addiction actually than about obesity. It was all about addiction, but about how people are moving away from pain. Humans, I think Epicurus said that humans move away from pain to pleasure. Like that's just the human, wouldn't matter what you're thinking about. And I just wonder whether, when people are taking in excess calories, and that's not perhaps the only explanation for carrying a high BMI, but there's a movement toward a certain degree of pleasure and comfort that comes from consuming food, and that's a psychological sort of side of this whole management. And we're approaching it beautifully from the bariatric side, but I wonder whether there could be a bit more emphasis too on the sort of the mental approach and understanding the psychology that leads us to consume where perhaps we shouldn't. I'm interested, Melissa, in your journey. We've talked about you going through the United States, and you will have come across some very influential people. Tell me, was there anyone that you found was a real standout in terms of a mentor to you? And I'm interested whether they said to you, Melissa, listen to this quote I'm going to give you because it's going to help you through your life and help you cope with the challenges of being a surgeon, which is not easy at all. Tell us about that. Have you had a mentor and a quote that we can pass on to any other young doctors that are listening to this?
Well, I'll start with the story and then I'll give you my word of wisdom.
Yes.
So my former chairman at NYU, he was recently nominated for and awarded an Icon in Surgery award. His name's Dr. Leon Pachter, and one of the bariatric surgeons I worked with, he gave a speech presenting him this award. And this guy is like in his 50s, the guy who presented, and he's like, Dr. Pachter, you're the voice in my head. And I'm just thinking, this guy is the voice in my head with every surgical decision I make to this day. And people came from all around the world, like chairmen of different hospitals and universities all around the world who had trained under him to pay their respects. And they're like, 100%, you're the voice in my head. But I will say that probably the best advice I learned on my surgical journey is that people are going to try to tear you down, and they're going to tell you, no, you can't do this, you can't do that, you can't go to the States, you can't be a surgeon, you're female, you can't start your own practice. And you just have to do you.
Yes. Yeah, that's inspirational. And I'm terribly sorry that you were ever treated in that way. You sort of don't think the world is like this, but clearly it still is. And,
there are only 16% of surgeons in Australia are female, which is an improvement. When I left for the States, I think it was about 9%. So it's improved, but it's still very low. It's going to take more than 100 years for us to reach gender parity.
Yes. Yes. Well, my son's a young doctor in his third year. His girlfriend, who's been stable girlfriend for a while, she's doing orthopedics, and so we've got one addition to the statistic.
An extra one.
Yeah, an extra one, but it's very inspirational. And so I would like to wish you well, with your practice, and I'll certainly be referring patients your way, and really appreciate your expertise and your time in discussing this with us today. And look forward to chatting with you again sometime. And you're getting married too. I haven't even congratulated you on your marriage, which is coming up. My gosh.
Thank you so much.
There's one lucky guy out there.
Thank you. Thank you so much.
You take care, and all the very best. Thanks for chatting. Thank you.
Thanks. Bye-bye.
I'd like to thank you all for joining me in the conversation with Melissa Beitner. She brings energy and enthusiasm as we redefine obesity, and we look forward to supporting her in her clinical practice here in Melbourne. Next week, there'll be a new guest for our podcast series, and we will be covering a wide range of topics in this series across many special interests. The discussions are not intended as specific medical advice for patients, but it's general information only and reflect the opinions of the guests interviewed. So requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@yohealth.com.au.